Please unmute yourself.
Good morning, everybody.
Good morning.
I'll just be going to start
Yeah,
my
please share your
presentation.
screen.
Ma'am, I'll just share my screen in a minute, ma'am.
Yeah, we can see your screen.
Ma'am, I hope I'm audible.
Yeah, you are audible. Clearly audible.
Thank you so much, ma'am. I'm sorry for the delay. Good afternoon, everybody. I'm Dr. Inara. I'm a consultant pathologist at Hakeem Sanauda Specialist Hospital and Cancer Center. This is the place we work. And today I would be going to talk about a single institutional study on driver mutations in lung cancer. So, smoking is the leading cause of lung cancer, and more than 90% of the smokers have more than 90% of the patients with lung cancer have a history of smoking. Even if they stop smoking, they reduce but never eliminate the risk of smoking, lung cancer. Lung cancer is a very sad disease, with 55% of the cases present with distant metastasis, 25% of the cases present with regional metastasis, and 20% of the cases are localized. This is a picture from Globicon 2012, which shows the top 10 global cancer, showing the incidence of lung cancer being 13% in them. The 5-year prevalence study of WHO, Globicon 2012, showed the Western Pacific region having the highest prevalence of lung cancer, whereas the lowest prevalence was seen in Africa. This is the world map showing regions in red showed highest incidence of male lung cancers per 1 lakh population. This world map shows incidence of lung cancer in female per 1 lakh population. The symptoms of lung cancer depend upon the place of the lung cancer, if it is a central, peripheral, or a regional spread at time of presentation. If it's a central growth, the symptoms can range from cough hemoptysis to pneumonitis. In peripheral growths, there can be cough, dyspnea, even patient presents to us as a lung abscess. In regional spread, the presentation can range from hoarseness to Pancoast syndrome to diaphragmatic palsy. Lung cancer is one of the most evolving cancer currently. Since the 1990 till date, there has been a paradigm shift in the treatment and classification of lung cancer, with of more evolution based on the targeted therapy. The basis of this lies in the DNA RNA proteins, where there is any transcriptional or translational error which causes this defects. The aims and objectives of our study were to evaluate the frequency and pattern of driver mutations, and to emphasize on performing these driver mutations in patients with lung cancer, to highlight the importance of a targeted therapy in lung cancer, also to assess biomarker specified groups of advanced lung adenocarcinoma, and to pair them with a specific palliative first line systemic therapy which have a proven clinical benefit. This is a world map which shows that how much variation in the genetic driver mutation occurs throughout the world, which makes it more important for us to study these driver mutations in each region. This study was a retrospective study. We pulled out of our records from January 2009 till date. And all the data was retrieved, analyzed, studied, and all the parameters which were assessed were all statistically analyzed according to the SPSS software 22. And over here, we present our data on oncogenic driver activating mutations of EGFR, ALK, ROS1. Also, a PD-L1 IHC was performed in these cases. We had about 80% of the patients were males and 19% of the patients were females in our study. The symptoms of presentation ranging from cough, bloody sputum to chest pain, and even some patients were not symptomatic when they presented to our clinic and had come for vague or some other with some other complaints. So the distribution of age was that maximum patient hailed from the second, followed by the sixth decade, and then the eighth decade, with the least number of patients in the ninth decade, more than ninth decade. 86% of our patients were newly diagnosed at our center, and 10% of the patients were previously treated at some other centers. We had a relapse rate of 2.34% in our center. We did a biopsy in 86.65% of the patients, and the other most common investigation which was done was the cytology of the fluid, which was done in 6.32% of the patients. According to the histological subtypes, we had 4 cases of lung neuroendocarcinoma. We had about 122 squamous cell carcinomas. We had, 212 squamous cell carcinomas and 122 adenocarcinomas of the lung. For adenocarcinoma and squamous cell carcinoma, the IHC TTF1 P63 was applied. And for favoring a diagnosis of adenocarcinoma, non-small cell lung cancer, which favors adenocarcinoma, a CK7 was also applied in the cases. For squamous cell carcinoma, P63 and TTF1 was only applied. Of the 432 cases of lung carcinoma, we excluded the 78 cases of small cell lung carcinoma, and we took only the cases of non-small cell lung carcinoma, excluding large cell neuroendocrine carcinomas, squamous carcinomas, leaving 122 adenocarcinomas with us, in which we studied the driver mutation in the stage 4 disease of the patient. We only study the driver mutation in stage 4 disease of the patient because our treatment protocols were based on the same way. Coming to the EGFR mutation, which was studied, why we tested for EGFR was because our patients fell into these subcategories. That is that at the time of diagnosis, the patients presented with the advanced stage carcinoma, or there was a recurrence or progression of the disease, or we wanted to differentiate from a primary from a metastatic disease. The molecular methods for testing of EGFR are 2. There can be a screening or a targeted method which can be applied. In our study, the maximum number of patients lied in the 7th decade, followed by the 8th decade, and almost equal proportion of patients in the 5th and the 6th decade. About 30% of the patients with the EGFR positivity were females, and according to the subtype of EGFR, we had maximum number of the patients exhibited a deletion in exon 19, which was 12.5% of the patients, followed by L858 region mutation in exon 21 and T790 mutation in exon 20, which was followed by a mutation of deletion in exon 19 and L858R mutation in exon 20, with equal proportion of mutations of L858R mutation in exon 21, deletion in exon 19, and T790 mutation in exon 20, and insertion in exon 20. Maximum number of EGFR mutations were seen in the 7th decade of life, and females showed more variations in EGFR mutations as compared to the males. The newly diagnosed patients had more EGFR driver mutations as compared to the previously treated and relapse cases. So a total of 38% of cases in which EGFR mutations were positive were seen in our study. Coming to the ALK gene fusion, which we studied, the ALK gene can be either studied by amplification or by protein expression. Amplification is the best method, which can be studied by fish, as we could correlate with the responsiveness to crizotinib. ALK gene positivity, the maximum patients died in the 8th decade of life, followed by the 7th and the 6th decade. In ALK gene, also females showed a higher positivity as compared to males. There was a EML4 ALK gene fusion which was seen, out of which 2 were newly diagnosed, 1 case of relapse was seen, and in the 2 newly diagnosed patients, 1 patient received curative therapy. For all these EML4 ALK positive patients, we did a FDF3 positivity also. In our study, 9.3% of our cases had an EML4 ALK rearrangement. ROS1 rearrangement was also studied. 2 patients had a ROS1 rearrangement, and both were in the 2nd decade, and both of the patients were males. 1 patient presented with bone metastasis. So 6.2% of our cases had a ROS1 rearrangement. Also, we studied the PD-L1 IHC according to the tumor proportion score, out of which out of the 32 patients, 18 patients had an IHC of less than 50%, and 14 patients had an IHC of more than 15%. So a 56.2% positivity of adenocarcinomas for PD-L1 IHC was seen. Also, one important interesting finding was that 2 cases showed a co-expression of EGFR mutations, EML4 ALK translocations, and ROS1 rearrangement. So why did we selected these markers for our study is that when a patient comes to us, the treatment is given according to the stage of the disease. Patients with a resectable disease are not studied for driver mutations, and in which their lung function is still preserved. In the stage 3 and stage 4 disease, we categorize the patients according to the EGFR ALK ROS1 positivity. If any of these markers is positive, we give a tyrosine kinase inhibitor for the treatment. In a PD-L1 enriched tumor, we give an anti-PD-1, that is pembrolizumab, for treatment. If we have a case of all negative biomarker, a platinum doublet chemotherapy with or without bevacizumab is given. Also, we do a CPS score, and a CPS score of more than 10 is said to be significant. Coming to the discussion, the basic of non-small cell carcinoma lies on histology, followed by immunohistochemistry. But with the modern evolving genomic classification in lung carcinoma, it is very important that we know that there is a paradigm shift from the 1984 till date, where only a KRAS mutation was known. And now, with the evolving of medicine research and various facilities, there are a various number of mutations which have been seen and are clinically significant in lung carcinoma. In squamous cell carcinoma, a PIK3CA amplification and an FGFR1 mutation is very important. In adenocarcinoma, ALK, KRAS, EGFR mutations are the major stakeholders. EGFR mutations, the TCGA group in 2014 has said that there are about 18 driver mutations which are statistically significant, in which 33% are KRAS, 14% are EGFR, 10% are a BRAF mutation. Also, they suggested that mRNA profiling should be done, and they have given us 3 groups: the TRU, that is the terminal respiratory unit, which expresses EGFR, and the proximal inflammatory and the proximal proliferative group. Also, with further research, they have said that there should be a DNA methylation. According to DNA methylation, the lung carcinoma patients are divided into 3 subtypes, which are the CpG island high, intermediate, and low subtypes. For EGFR mutations, 90% of the mutations are in frame deletions in exon 19 or point mutations in exon 21. 10% of the mutations occur outside these hotspots. Mutations in exon 20 are associated with tyrosine kinase resistance, which is important with respect to targeted therapy. Gold standard is direct sequencing. Now, who are the candidates for EGFR mutations? With patients with receptor overexpression, amplification, activation mutations, or overexpression of receptor ligand, or there is loss of negative regulatory mechanism. There are 2 types of targeting pathways for lung carcinoma. That is the monoclonal antibody, which acts in the extracellular domain, and the tyrosine kinase inhibitor, which act on the intracellular domains. With EGFR tyrosine kinase inhibitor therapy, the objective response rate is seen up to 90% with a double median progression-free survival and lesser side effects as compared to conventional chemotherapy. Also, it is seen that 40% of the Asian population have a recurring EGFR tyrosine kinase mutation, and studies have shown a higher survival benefit with gefitinib as a standard chemotherapy instead of the first line agent in EGFR mutations. Our study had a 38% EGFR mutation, which is also very significant, as they say various studies in literature have said that there is an increased EGFR mutation, genetic driver mutation in Asians as compared to that of Caucasians. We had a lesser KRAS ALK mutations which were seen. In ALK gene fusion, it is due ALK gene account for are seen in about 5% of the adenocarcinoma of lung, and EML4 ALK fusion is the most common fusion which is seen. And the treatment of choice for this is crizotinib. ALK gene fusion is usually seen in younger age group, and they are either never or light smokers and have a signal drink morphology on HE. Why we had a lesser ALK gene fusion mutation which was seen is mostly because our major population was males, and the females which we had in our study were in the higher age group. They were more than 70 years of age. So this could be one reason why we had a very low ALK gene fusion which was found, which was about 9.3%. So coming to the therapy, EGFR tyrosine kinase inhibitors and ALK tyrosine kinase inhibitors have shown a better overall response rate, a better progression-free survival rate, and a better overall survival in months as compared to other therapies, which make this study very important in our region, as our region has been declared as a tobacco capital of the country and has the highest rate of new number of cases in lung cancer. In our study population, we had 355 patients who are still on our follow-up. With this, we would like to emphasize that redefining lung carcinoma according to driver mutation is very important, so that we have a tumor diagnosis which is more meaningful for a therapeutic targeted therapy to the clinician, as it has been suggested that more than 75% of the cases of lung adenocarcinoma have a better overall response rate with targeted therapy. I would like to conclude by saying that targeted therapeutics have clearly improved the prognosis and quality of life for a substantial group of patients with advanced non-small cell lung carcinoma. Also, molecular testing is presently limited for advanced stage patients, and same molecular aberrations can be tested on different platforms. Molecular therapy will develop resistance, and there will be newer mutations which will be a challenge for us, and we are not yet ready for to perform all these tests on a single platform with our resource limitations. So we should have a multidisciplinary approach for diagnosis, which would require a good correlation of the pathologist, clinical findings, radiological, molecular, and surgical findings of the patient. Also, I would like to say that our study is a stepping zone for a further large-scale study in this high endemic region of lung carcinoma, so that we can identify and classify the subgroup of patients for a tailored targeted therapy. Our recommendations would be that lung carcinoma having a very poor prognosis needs to be dealt differently, with more driver mutation studies to be conducted in our region. This is the first study we have conducted and are going to publish to our knowledge. Rural areas need to apprise a health policy for decision making for lung carcinoma, and the necessity to search for setting up a proper algorithm for diagnostic and prognostication of disease, so that all the clinicians and pathologists are at the same page, and it is easy to choose the modality of treatment in this resource poor setting. opportunity to make a headway in basic understanding of this lethal disease is very important. When we have an era of large global studies, large scale global studies, attention must be paid to possible genetic differences in the population before we can generalize therapy for all patients, and stratification should be done based on the country of origin so that we can understand and help improve the different underlying issues. Accurate molecular characterization of this tumor is very necessary for enrolling of our patients in clinical trials so that we can define which patient group will benefit from our set of targeted therapy. In the end, I would like to say that the future of lung carcinoma lies hand in hand with H&E and driver mutation and molecular biology for a better and a tailored approach. Thank you so much.
Thank you, Dr. Inara, for a very comprehensive presentation of the topic and very nicely presented. So I request if
Thank you so much.
any of the participant wants to ask any question from the speaker, or the questions can be mailed to the UCG team and can be forwarded to the speaker later on. Thank you, Dr. Inara.
Thank you so
It's a
much, ma'am.
very upcoming thing like novel molecular targets and the targeted therapy. They are really changing the course of the non-small cell lung carcinomas. So thank you
Thank
for
you
the
so much, ma'am.
presentation.
It was my pleasure to present this presentation in these with such esteemed speakers. Thank you so much, ma'am.
Now I call upon the